So as long as you are calling us with the identified information, you will be able to be connected to one of our consultants who will then walk you through the best practices in treating that case. You can also call us with broader questions, including dosing, maybe just what medications for which substance use disorders and when to use them. We also offer education like today's webinar, usually around the lunch break to accommodate your busy schedules. Another education component is our echo clinics, which meet once a month and are more collaborative. And we also offer Max for Moms, which is all of our services for Max, but for pregnant and postpartum patients and providers who work with those patients. I'll put our information in the chat. But before I do that, I am just going to introduce today's speaker. Today's speaker is Dr. Sarah Merritt, and Dr. Merritt is triple board certified physician with ABMS qualifications in anesthesiology, pain medicine, and addiction medicine. Currently, Dr. Merritt is Currently, Dr. Merritt is active as a volunteer in the medical community in addition to her medical practice. She was appointed by the Maryland Department of Health and Mental Hygiene as a member of the Technical Access Committee for the Maryland State PDMP. She also is a co-chairperson on the Legislative Council for MedChi, Maryland State Medical Society, and the MedChi Board of Trustees. And she is also our pain management consultant for MAC, a great resource to tap into when you do call our warm line about any pain management questions. So Dr. Merritt, I will turn it over to you and feel free to get started.
Okay, thanks so much. And sounds like you guys can see my slides, as Bridget said, so great. All right, well, thank you for that nice intro. Welcome to today's webinar. And this is actually the first time that I've given this exact talk, and I decided to call it Taking the Sting Out of Pain Management, because pain is a painful topic for a lot of folks who are clinicians. Pain can be a really challenging complaint. The idea behind this webinar also, in addition to just getting maybe general CME for it, as you may know if you're attending, that it can also meet some of that DEA 8-hour training mandate, that one of the learning objectives and goals is to provide background on pain assessment and treatment. And so we're going to talk through some of that, kind of book knowledge, some that you've had before probably in your trainings. But I think there will be time for questions. And so please feel free to also put questions in the chat. If you have thoughts or questions that come up, I have obviously some didactics and kind of a case example to give at the end. Whoops, and then I got to know how to advance my slides. There it is. Okay. And you've heard from Bridget, of course. This is our Max visual. If you have a copy of the slides, then this information will be here. The website is marylandmax.org, is an easy way to find us. So our objectives really are around making sure that all learners can describe a comprehensive assessment process that might include pain scale, history taking, and possibly even physical exam techniques. Attendees should be able to outline key components of a pain treatment plan and the different pieces of that, and then recognize the importance of a multimodal and multidisciplinary treatment intervention. So I just wanted to start with the kind of idea here that the chronic pain by the numbers is really a huge problem that, of course, we'll touch a little bit on both acute and chronic pain assessment. They're often assessed in very similar ways, but really, it's chronic pain, that pain that goes on for 3 months or more, that can be so disruptive to life. That's a huge problem in the US in particular. More than 1 in 5 adults would tell you that they experience, and then 8%, so not 20% is who have chronic pain. For 8% of of them, a little half or a little under, have something called high impact chronic pain. And that's the type of pain that becomes very disruptive to life and function. And those are patients who are really very often unable to sustain work outside the home. Chronic pain, of course, is the number one cause of disability and disease burden actually globally. And the costs are just astronomical because, of course, there's the cost of treatment, but then really the cost of lost productivity and any government programs to support people really drives these numbers through the roof. So we kind of all have a sense of what acute pain is. And we probably, pain is the number one reason that people seek medical care, right? It's a primary driver that gets people to go to the doctor, to go to the ER. Very often it's acute pain of some sort will drive us to change our behavior. And we often think of this type of pain as something that's a warning sign. It's warning of potential harm or tissue damage. Often acute pain results mechanistically through stimulation of something called nociceptor or pain sensors that are in the periphery in the body. Excuse me. Examples of acute pain would be something like a surgery, like a joint replacement, an acute injury. A person with a wound could have acute pain from that. And this acute pain model is sort of a signal and response. There's something going on in the periphery, and so I feel it in my brain. There are some different tools sometimes that are used for acute pain versus chronic pain. What's very often, probably the most common scales that we're probably all familiar with as clinicians would be like a NRS or a visual analog scale. An NRS would be that, rate your pain from 1 to 10 numeric rating scale. It's done verbally. The VAS, actually requires that visual, the number line 1 to 10, and the patient pointing. And there are studies where they've compared, you get different results depending how you ask it, or if you give the person the number line. So those actually give you different results sometimes. And then what about people who, might not be able to verbalize? There are nonverbal pain scales for adults and children. There are some tools for dementia. Of course, behavioral pain scales where you might observe behavior, or in, say, a critical care setting where a patient also is nonverbal. There are ways to do this. And we do think that for these acute pain assessment tools, one of the important reasons to use them is because early intervention is going to be associated with better pain outcomes and just better clinical care. So we talked about acute pain, but kind of where we're going is very often clinicians are needing to treat chronic pain. And so what is pain? What does that even mean if somebody has, ongoing pain? So there's this International Association for the Study of Pain, the IASP, and this is kind of like the academic pain organization. And so like the people in this are very often people who might be studying pain models in animals and translating, some of the science into human medicine. And you may have heard this first part of the definition, but they've really expanded it in recent years. They revised this definition just a couple of years ago and added some things. So pain is described and understood as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So I think it's worth pausing for a moment that it's not just a sensory experience, right? So if we're going to understand pain, if this talk is to understand, pain assessment and treatment, that pain is not just a sensory experience. And I think if you just showed up on the wards, you might think it's all mechanical, mechanistic, that acute pain model that I spoke about earlier. And frankly, your patients think that. But actually, as we study it, as we learn more, there's more to it, that pain is really an unpleasant sensory and emotional experience. It's not always that it's not always reflective of tissue damage. It sometimes just resembles something like tissue damage. I think down here too, pain and nociception are different phenomena. So the pain experience is kind of, again, that sensory and emotional experience. Nociception is that like kind of transduction, moving that signal of, you know, okay, I've broken my arm to the brain. That path, that sensing is the nociception, but the pain is the experience, the thing that I may feel or experience through my brain and my central nervous system. Throughout their life experiences, individuals learn the concept of pain, and a person's report of an experience as pain should be respected. I think that's really interesting and different maybe than, you know, decades past in medicine when we might have been taught in a, you know, a generation prior to me, this adage, you know, if a patient has a complaint and multiple things, there was kind of an adage in medicine, if everything is wrong, then nothing is wrong. But actually, no, like a person's report of an experience as pain should be respected. It doesn't mean every report of pain needs more opioids, right? That's not necessarily the treatment, and that's where we're going as we talk about treating pain. But that we should take in that report, process it, and think about what are appropriate treatments for a patient's report. And to kind of break that break that concept down a little more, I like this quote from Margot McCaffrey, who was an early hospice movement pioneer, so well known in that field. Pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. So now we have 3 types of pain that are described. And I think it's helpful to know there's this kind of like newer type, maybe in the last 10 years, that we've adjusted this table in terms of understanding pain. We used to just talk about it being as just nociceptive or inflammatory, that kind of acute pain model, or neuropathic from damage to a nerve. But then there's actually this other type too, which is called nociplastic. I think is the easiest word for it, but it's a newer word, and the word you might have heard before would be central sensitization, because that term I think has been around longer. So the stimulus for each of these things you can see is compared and is different. In this nociceptive or inflammatory, there's more like tissue damage. This neuropathic type of pain model is damage to a nerve itself. And then this central sensitization or nociplastic type of pain is a type of pain that we have associated with fibromyalgia and some other pain disorders where there's actually a dysfunction in the central nervous system. And we don't have great testing to necessarily show that a patient is experiencing this by some type of, say, objective test. It doesn't mean that they're not experiencing pain. It just means that we don't have an objective test that shows exactly what it is. So we talked about acute pain as being that nociceptive and inflammatory type of signal and processing. Patients who have chronic pain have more of a long-standing pain picture that extends beyond the usual recovery period from a short-term stimulus. And so usually after 12 weeks or 90 days, someone might meet the criteria for having a chronic condition or having chronic pain if they've had a problem go on so long. And so on the one hand, there is kind of this model where like acute pain may become chronicified or chronic pain if it goes on for a period of time. And then there are other times that chronic pain really just occurs without a clear, single inciting onset. So there are maybe some different tools that we might use to assess chronic pain. Rating scale that we mentioned earlier would be appropriate tools to use potentially in assessment of chronic pain, but they're not really that informative. They're going to give you like a 1-moment snapshot of what that patient is feeling in that moment. And what some of these other tools might give you is a bit more detail about their function. So the McGill and the Oswestry Roland Morris Disability Questionnaire, these are more detailed questionnaires that can give you information about patients' improvement and function. Very often, if a patient's in physical therapy, they will get maybe a McGill or an RMDQ periodically during their PT visit to compare and track improvement in function. The other 3-point questionnaire that's really useful for clinicians seeing patients with chronic pain can be this PEG scale. If you may or may not have heard of this one, if you haven't, I think it's really useful if you are treating patients with chronic pain. This is a 3-question, and I kind of bulletized the 3-question scale. It's graded 1 to 10. What's your pain number on average in the last week? So basically asking the patient for an NRS score, a numeric rating scale score. What number describes how much your pain is interfering with your enjoyment of life? 1 to 10. And then what number describes how much your pain has interfered with your general activity? And so this gives you some picture of not just a pain score in a vacuum that may or may not be meaningful, but there's also a functional component here. The other portion of history and pain assessment, I think, would be making sure that one has a good pain history in terms of understanding the patient's symptoms. So if a patient presents with a pain complaint, we want to assess it. We might use some of these rating scales that were mentioned, particularly a PEG or the NRS are like the easiest ones to just implement without much ado or additional forms. And then you might think about getting their narrative history. Now, of course, we've probably all been taught in terms of taking a medical history and physical. There are some different ways to think through the questions that you may ask. This is one that I like. There are lots of others, but this PQRST sort of sticks with me, and I can kind of always pull that up. So what, for pain, what provokes it or makes it better? What makes your pain better or worse? What's the quality or quantity of the pain? Does it radiate anywhere? What's the severity of it, and what's the timing? Timing might also be just what's this associated with? Is it worse in the morning? Does it make a difference when you get up out of a chair, moving from sitting to standing? All these kind of questions that might help inform and understand better, what a patient is experiencing by asking all of these questions. And so this is just part of taking a general history, of course, but a pain history in particular really starts to incorporate all these items. Now, I think that this all takes some time. So taking some time to get a good narrative history is really the opposite of this kind of idea that providers aren't listening, that clinicians are not paying attention to pain complaints, right? If you've heard about this idea that clinicians are, medical gaslighting patients. So none of us want to be guilty of this or this perception, right? So really what we can do is find ways to engage with patients, show our concern, and act, in a way that's appropriate to us and our training and our scope of practice to, order testing or treat with whatever we think is appropriate. So we don't want to be interrupting, downplaying, refusing to order stuff. But on the other hand, ordering tests that actually make a difference, not just, we're not ordering things blindly just because the patient asked us to. If we're taking good history, if we're really listening, if we're engaging, all of that is building the therapeutic relationship, frankly, with the patient. Because, in my practice, when we help someone with chronic pain, we very often help them with what they perceive to be their worst problem. So often the obstacles that people with high impact chronic pain have are really disruptive to life and their general function. And so it can be really meaningful if we can find ways to engage with them and find a treatment plan that's helping. And very often, as we kind of maybe shift into the treatment portion of our discussion here, very often treatment for chronic pain doesn't always make it completely go away, but if we can make it more livable and help people improve their quality of life, then we've done something really impactful. So how do we think about developing an effective treatment plan? And so really for acute or chronic pain, really I think an effective treatment plan generally is going to involve a variety of different multimodal and possibly multidisciplinary interventions. And so by multimodal, we might mean, say, pharmacologic and non-pharmacologic therapies. And some examples are here. We'll talk through some of these. But then also tailoring that treatment plan to what's going on with the patient. It's going to need to be something the patient will engage with. And so an effective treatment plan isn't just like, hey, I think you should go to physical therapy because I think you need to be more active. An effective treatment plan probably involves discussing, I think you should go to physical therapy. How do you think we can help you do that? Working with a patient to find out what have been obstacles for, similar treatments in the past. And finding ways to engage, particularly, I bring up physical therapy because it is a popular, effective, helpful modality for many people, most people with chronic pain. But we have to find ways for the patients to be able to engage with it, and there are a variety of obstacles we may need to talk through. So to talk through kind of some of the, multimodal treatments that are available for chronic pain. I thought this graphic I pulled from the web and this website called Very Well. But interesting, as I pulled it, it's really just showcasing the pharmacologic treatment options only. Now, this webinar I think is mostly for clinicians and prescribers, but I think we all know that medications are not the only available treatment options for chronic pain, right? But I think there is a perception maybe on the part of some patients and some people in the public that those are the treatments, right? But the treatments would include, and probably these are probably in reverse order of where we should start. Maybe we should start more down here in the lower right with things that are less invasive. Prescription opioids, not number one top first line therapy for acute or chronic pain, right? Starting with things that are safer and more readily available. And for severe pain, are prescriptions opioids appropriate for acute and chronic pain? Absolutely. But it's just going to depend on the situation as far as where we start. And I think if we're talking about pharmacologic treatments for pain, it's worth mentioning the WHO analgesic ladder. This is a concept that's been around for decades and really started with this one on the left here. And initially, the analgesic ladder was formulated to think about cancer pain when opioids were very rarely prescribed, but certainly need to be prescribed at times for patients with severe pain, and particularly with cancer-related pain, that can be inappropriate intervention. But to make clear, starting with non-opioids and adjuvants, and then progressing to a lower potency opioid and to a higher potency opioid if needed. This schematic has been updated a little bit to include also that there are things like invasive and minimally invasive treatments. So things like injections, et cetera, injections, even some of the like implanted devices for chronic pain and some of these things. There are certain treatments that might be appropriate in this type of analgesic ladder stepwise process of treating patients with, pharmacologic and other medical therapies. And I wanted to include this slide in here. We're not necessarily diving into the fine points of, say, opioid prescribing, but I do like this 10-step universal precautions graphic, because I think it really puts a fine point on, how to think as a clinician when treating a patient for chronic pain. And so this is from a paper by Doug Gourlay that is about universal precautions around opioid prescribing. And it's just that, universal precautions that are appropriate for most any time we're prescribing a intervention with a risk, this type of intervention that has a risk. So as a clinician, if we are prescribing, opioid medications for pain, we should think about having a diagnosis and an appropriate differential. We should think about having a psychological assessment, including risks of addictive disorders. We should have an informed consent and a treatment agreement. We should assess the patient's pain level and function before and after the intervention. So we kind of touched on, what are some of those ways to measure pain level and function. Some of it's just history taking and just asking, what can you do taking this medication, or since I sent you to PT, what's changed? So assessing pain level and function before and after the interaction. And of course, we're documenting this, right? This is part of our note, part of our treatment of the patient. That if we're using an opioid, that we would think of it as a trial initially, that we're going to just try it out and see how it goes. And that maybe with or without adjunctive medications and therapies, reassess, regularly assessing the 4 A's of pain medication. So this would be side effects, aberrant behaviors, these other parts of your documentation, reviewing pain diagnoses and co-occurring conditions, and then documenting, of course, your initial and your follow-up. Okay, so that was kind of what I wanted to say around pharmacologic treatment. So as clinicians, if we're working with patients with significant chronic pain, there's also all these non-pharmacologic treatments out there. And how can we help engage people in those? So there are things like physical therapy, exercise, stretching, Tai Chi, meditation, massage, acupuncture. I've really just listed some of these. And, many of these things are certainly physical therapy, acupuncture, counseling are things that we can often use the, healthcare system, the health insurance system to cover, to make referrals. Of course, there's just discussing with patients their own, lifestyle interventions. Some patients are going to be more, more receptive to that, more proactive in their own, lifestyle modifications for non-pharmacologic treatment of chronic pain. But I think that, really just to acknowledge that all these things that may be like self-care in some way also are non-pharmacologic treatments and kind of maybe even maintenance treatments for people with pain. And so just to mention multidisciplinary care, as medical clinicians, if we're treating patients and considering, medication therapies, non-pharmacologic therapies, I think for anyone with a significant chronic pain problem, it's important to consider how other clinicians, how other disciplines can help the patient. So again, very often in my practice, it might involve referring a patient to physical therapy for strengthening, for maybe balance work, generally functional restoration, we can think of that. Potentially psychologists to address, psychological factors contributing to pain. And certainly pain specialists such as myself can help for advanced interventions, for coordination of care, and maybe for, talking to patients in certain ways about their care. One maybe pearl that I would share about like the psychologist referral. Sometimes, we'll find that our patients with significant chronic pain already have a counselor, and that's always nice. If I'm recommending someone to consider seeing a counselor or a psychologist around pain, there's kind of a way that I will tend to couch it, and very often I'll just try to make the point, hey, I'm not saying this is in your head. That's not what it is at all. It's that this is a real thing, and dealing with it is a lot. And so we can all use some help with dealing with life better, with coping with the stresses that we have. And so that's really, some of the way that I think that the psychologist could be helpful for you. So that's kind of the conversation that I'm often trying to have with my patients, that, and it's a fine point, right? Because it's not hard to just say, hey, go see the psychologist, see me in 3 months. That's not going to be all that effective or helpful, and the patient's going to get the wrong message. So really, like, taking that moment to really talk about why, I think can be really impactful. And then our goal is really that we have a patient who has a multidisciplinary care plan that's just part of their maintenance and part of their getting through things if they have significant pain, and letting the patient know, hey, this is part of the treatment plan, so that they understand, not just like, hey, I'm trying to get rid of you, go exercise with the physical therapist for a little while. No, this is really hopefully a long-term relationship, and we want to find you some go-to people, so that when you have a setback, you can go see the physical therapist, or you can go see the psychologist, et cetera, as needed. All right. So I do have a case maybe to present for a few minutes. So this is just a case of a patient who had kind of some medical complications related to pain care ahead of my seeing her. And I think it just was an interesting case, because she had been hospitalized here, as you can see, had been hospitalized for a GI bleed and got to a hemoglobin of 5.6, really just due to overuse of ibuprofen at home. And her complaint was that she was having significant low back pain, radiating into both legs, had some neck pain complaints, but mostly it was really her back. She did know that she'd had a back injury of some sort in high school, and episodes of low back throughout her adult life. And then at some point it became, again, very difficult for her to bear. So she came to see me after this hospitalization, and she had this lumbar MRI. I guess I've just copy pasted some of the findings here, but she has she had some nerve impingement, some neuroforaminal stenosis in the L4-5 and L5S1 area here, and then this these white parts in the vertebra, right? This is a sagittal view, and this is really showing kind of some bone edema, and what we think of as probably active degeneration, these called modic changes on the MRI, is probably showing these are areas of stress. So she has some findings that support, active degeneration in her spine that's probably causing some of this discomfort. So, to help this patient, again, she'd been treating at home and got herself in a situation of having a significant GI bleed from overtaking ibuprofen, which she acknowledged she was taking way more than the labeling. We were able to start her in physical therapy. She just hadn't had any basics, frankly. She was kind of self-treating at home with too much ibuprofen, feeling a little distressed about it. We got her plugged in with physical therapy. She already had a counselor for underlying depression, and we had her work with her counselor and discuss around her pain challenges and have the counselor try to help her improve her pain control through the strategies they were using. We also made some changes to her pharmacologic management. She had a tricyclic antidepressant added for every day at night, and I did write her a small amount of a low-dose opioid medication, which she took sometimes for worst pain, but not every day, and was eventually able to stop that. Interventional wise, she got some injections to help with lumbar facet related pain. She went to see the spine surgeon and ultimately had improvement with the short-term medications and injections. Got to where she had kind of a livable level of pain and was able to cope. All right. That's what I've got. I'm on the shorter end of things, but I'd be glad to have some discussion if folks have questions or want to talk about pain assessment and treatment.
Thank you so much, Dr. Merritt. This is a great amount of time to do some questions, and our first one is a little long, so I'll read that to you. Let me know if you need me to repeat any parts. But this attendee wrote, I work at an inpatient rehab facility. Pain is a huge problem for our patients. Patients are sometimes drug seeking and other times needing to legitimately find other options for pain. I often am conflicted about how to treat these patients, especially in this setting. If we were to try to refer to pain management, would that be a setting that they specifically try other options for patients with substance use disorders? What is the best way to handle these types of patients?
Yeah, that's a good question. Yeah, that's a challenging area for sure. That's a challenging area for sure. I do think you can refer those patients to pain management for consultation. It depends a little on the pain management doctor and really communication and proactive, maybe with the consult sending some additional info. Because having been on the receiving end of some of those referrals at times, it's so helpful when we have a little clinical information from the referrer to know, hey, I'm not expecting you to take over their buprenorphine or methadone, or the patient, isn't asking for that. We're legitimately wondering, what are the things we can do other than opioid prescribing? Or sometimes, short-term opioid medication might be okay. But I think just to kind of clearly articulate whatever, the goal or whatever the goal is. Some of those patients are going to be, it depends what their diagnosis is. If they have maybe an orthopedic problem, they have a knee that needs to be replaced, they may benefit from knee injection, consultation with orthopedist, et cetera. And frankly, I guess, depending if you were to have a handle on that specific problem, frankly, the referral to the orthopedic might be even a better first line, depending, because certainly there are patients who will benefit from, surgeries and/or injections with their orthopedic as well. I do work with a patient population of people with substance use disorder also, and it's challenging. You are correct that the rate of chronic pain is higher in people with substance use disorder than in the general population. So it's probably about twice as much, like the self-reports. It's probably reported about twice as much in a substance use population. And also, if you, in survey data where they've talked to people with opioid use disorder particularly, and talk about, did you have pain prior to having your opioid use disorder, very many patients, I think it's around 50% of them, will say yes, that having, seeking pain relief may have been part of their initial use of opioids. So that's kind of an interesting and challenging finding. I think referring to a pain doctor who's at least a little bit familiar or not totally freaked out by the idea that, they might treat a patient with a substance use disorder, is probably one helpful thing, considering, again, like an orthopedic consult if, depending on what the pain problem was, and maybe optimizing pharmacologic management with, a medication for, an anti-epileptic drug, one of the on-label medications for fibromyalgia, if the patient met criteria for that, et cetera. I think those would be thoughts I would have. And certainly those are things that, on the one hand, in the inpatient rehab facility, you probably could prescribe some of those medications yourself, but you may not want to. It may be better to almost compartmentalize that treatment, with another provider. And frankly, then that becomes that multidisciplinary approach, because if you're the, inpatient rehab person, then you can focus on those issues and then have a pain person who's able to try to focus on the others. But I agree, that's a challenging problem. And working in a methadone maintenance program with consumers struggling with acute and chronic pain. Yeah, I think it's true. I would say, being that, in my practice setting and in private practice, I have one nurse practitioner at a methadone program who does refer us some patients. But it's frankly just not a common referral pattern that I see. But I think there are patients who could benefit. It's challenging because pain may also be multifactorial. But for those patients, say in a methadone, here's just an example, like case that I may have seen in the past. Patient in a methadone maintenance program, they have a significant, back pain. I would kind of start with those basic questions. Have they had a recent MRI? Have they been to physical therapy? And if they've had a recent MRI, are they a candidate for something like an epidural steroid injection? Again, it's not going to, the way that I tend to talk about that with the patient, hey, this epidural may not necessarily solve your whole problem, but if we can help move the needle, get you feeling a little better, get you moving better, that's really what's going to be able to move the needle.
Thank you so much, Dr. Merritt. We still have plenty of time for questions, so please enter them into the chat. Someone just asked a follow-up question. Is that a cortisol shot?
Yeah, so like an epidural steroid injection is like a typical intervention that like an interventional pain doctor like myself might do. It's an ESI or an epidural steroid injection. The steroid cortisone is a type of steroid. The one that is probably the most popular is like either Depomedrol or dexamethasone. So it's not necessarily cortisol or cortisone, but it's like cortisone's cousin. When a patient asks me that, that's kind of what I'll tell them. It's like, well, it's the cousin of cortisone. It's just a different one, but it's a steroid. And those are injections that are done with guidance these days. We also have things like ultrasound for knee and hip injections, ultrasound for shoulder injections, trigger point injections, etc.
Thank you. The next question I'm seeing is, I have a patient with chronic pain after a fall 11 years ago on her tailbone. She did steroid injection 3 years. She stopped and now is leaving with pain. She had an MRI and an X-ray. What is your suggestion?
Yeah, kind of revisiting probably some of those things. If that was a new consult patient in my office, I would kind of look at what imaging they have. I would probably talk to them about, would it make sense to do an injection again? I would probably talk about PT also. So physical therapy for pelvic pain, tailbone pain, etc., can be helpful. So I'd talk to the patient about what their history or experience with that was. Did they ever do that? And, it kind of depends on the severity. I mean, there are patients that will have a coccygectomy. You can have the tailbone removed. There are some radiofrequency procedures to kind of burn some of the nerves around the tailbone to shut down some of those pain signals, and some things like that. So, the exact plan would depend on the patient, but I think, least invasive, I'd think about, physical therapy, repeating an injection if it's, well, I guess maybe I'm misreading this. If you did it, I don't know how long ago the last steroid was, but if it's been 6 months or a year, it could be worth reconsidering. And maybe on that topic, right, as somebody who, we do injections for pain. Very often patients are hoping that we can do an injection and fix their whole problem and they'll never have it again. And unfortunately, like a lot of what I do is really palliative care, frankly, right? It's like we're just trying to make the situation better, help them to move more, do more, and then that's really what sustains improvement very often, particularly like with the low back pain patients that we see. And so it may be, even just adjusting that patient's mindset, like, hey, you may just need to get like a tailbone injection like once a year or twice a year, and that may just be like part of your care plan. Patients don't love that because it's admitting like we don't have a cure for this, but what are your other options? Your other options are, do you want to talk to the orthopedic about getting your tailbone removed? I mean, that's one of the options. So I think on the one hand, it's kind of unsatisfying because patients sense that like there are just things that we don't have a fix for. But like the mindset shift around, this is part of my plan. And as long as if you have an injection that can help you for 3 or 6 months, like that's a good injection. If you get to like, this helped me for a week, okay, that's not an exciting injection to repeat, right? Like a week of relief for most people is not like super exciting. I work on an inpatient palliative consult service, and one of the barriers we face is getting some of these interventional procedures done while on inpatient. Do you have suggestions for this? Your anesthesia department. I used to work in a private hospital in North Carolina, and we were part of a big hospital-based group, and we did inpatient procedures. And it was really because, we were part of the big anesthesia group that did all the anesthesia for the hospital. And so it was like just part of the deal. If you have this like nice contract for the hospital, you have to do some inpatient procedures. So we did that. But it's never going to be like a good revenue driver for anybody. And so, and then I guess with the Maryland Total Cost of Care program, those incentives are different anyway. I think working with the hospital and or the anesthesia department to think about, would there be a way? I think that's what it would require, would be some of your in-house people to have a motivation to pick that up. Many of my patients have reported that insurance, Medicare and or Medicaid have denied requests for PT. Yeah, I would need more information on that. So, Medicare is really easy in certain ways. Like if you send Medicare a clean claim is, codes for physical therapy, appropriate musculoskeletal diagnoses, they're going to pay you, within 15 days. And that's just what it is. Medicare will need reauthorization for PT, and you will get to a point with Medicare that you can reach, there is an annual cap on how much PT. So if you had a patient tell you they were trying to go for the first time and they were denied, I would say that doesn't sound right to me. I need some more information, because that shouldn't happen like right out of the gate for Medicare or Medicaid. But if they've done, hey, I've done 8 weeks of PT on my knee, they're not approving any more PT on my knee, that's probably true. Hey, I've done 8 weeks of PT and now I want to do my back, they actually should be able to approve the back. There are ways around it. And some of this, I'm not a physical therapist. My practice doesn't bill physical therapy. But, I've been around the block enough to know a little bit about how it works. If you are working with the right physical therapy partners, then the physical therapists know how to work with those restrictions, because there are restrictions and it's their business to know, how to work with that. And sometimes they will need, different referrals from you. Some of my work, frankly, is writing updated PT referrals and making sure that the right diagnoses are on there and that kind of thing, because it enables it to happen. Or their copays are too high. Yes, that is a true significant obstacle. Medicaid, that shouldn't be the case. Medicaid shouldn't be the case with the copays being too high, but certainly with Medicare, there may be significant coinsurance, and definitely with private insurance, it will not be uncommon for there to be significant copays. Depending on the physical therapy place, many of them also can get the patient a home exercise program. So maybe a little of this physical therapy thinking would be like not taking no for an answer. Like, my copay is too high, so I'm going to sit on the couch and eat potato chips. No, we're not doing that. My copay is too high. Okay, well then let's go to 2 visits. Let's get you a home exercise program, and let's have you do that at home. But that is the copay is a significant obstacle that is hard to deal with, and sometimes the answer to that is home exercise. Oh, and then this person with the sacrum coccyx did radio frequencies. Okay, well, that's good. So that was tried at least. Radio frequency, did PT. Okay. Yeah, and I think there are. Yeah, I think that she is giving up kind of thing is interesting. If I was talking to the patient, I might ask them. I'm like half psychiatrist. Hey, what does that mean? That you're giving up. I mean, giving up might be deciding to live with it, and that is okay. Giving up being, I don't want to live anymore. Okay, and we need to have a different conversation. That's not good. But what does that mean? Or I'm going to stop looking for answers to this because I'm going to accept that I have this condition and I have chronic coccyx pain. Okay, that might be a thing that would help you feel better, is if you would decide that you're going to live with that. Does it seem like there's more difficulty getting Medicare, Medicaid approved for treatments, tests, and procedures? Yeah, I think Medicaid, yes. I think we probably all practice in Maryland, and there are the Medicaid MCOs, the managed care organizations, and very many of them do have specific criteria for MRIs, physical therapy, et cetera, or like some of the injections and things that we do for the Medicaid MCOs, they may want us to document very granular level, like how much physical therapy the person's done, when they did it, things like that, in order to approve a more invasive procedure like an injection. And so on our part, it's really just a matter of understanding the payer landscape to deal with that. And so we do, because that's our area. Medicare is easier, frankly. Medicare, again, if you submit them a clean claim, they're going to pay you within 15 days. If you're the MRI place, there's no prior authorization, et cetera. Medicare is usually not quite so bad. Medicare Advantage, that's something else. So just to not conflate those two, because your Medicare Advantage patients, there's a whole soapbox here that I could get on about those, but those create a lot of obstacles that are probably not good for patients. Oh yeah, good question. When you prescribe an opioid, which one do you tend to try first for someone with an existing opioid dependence? Hard to know. If we were talking about a patient in a treatment, setting, right? If a patient was, say, on buprenorphine, maybe they were like opioid dependents taking buprenorphine, the textbook would suggest a higher potency opioid, and so that might be like hydromorphone or Dilaudid, comes in an oral form, and high potency that it, binds very avidly to those receptors. If that patient we're talking about is opioid dependent, they're taking opioids every day, they may have a certain number of their body's total opioid receptors occupied, by opioids at any one moment. So how are we going to adjust that, or the short-term opioid that we give, is either going to go to unoccupied receptors, or will some of it be strong enough to move off some of that buprenorphine? So I would say, in like a surgical patient on buprenorphine, like the hydromorphone would be a good option. But certainly like a higher dose of oxycodone may be appropriate also. Would the same be true of somebody on methadone? Yeah, I think exactly. The concept is the same, that person on buprenorphine or methadone daily has a certain number of opioid receptors that are just occupied all the time. They're occupied differently. That methadone patient, those opioid receptors are full of a full agonist medicine that's turning the opioid receptors on all the way. And those buprenorphine receptors, those are like halfway on, right? So it's this dimmer switch, but they're on nonetheless. Yeah, and that question about like, not all providers have knowledge about substance use disorder. There's possibility to cause harm with painkiller prescriptions, for sure. Yeah, I think it's a real challenge, and hopefully that's where we're getting to with some of this, like, more training for prescribers to make sure that prescribers aren't overly free with medication. I think there's a balance to be had of prescribing medications when they're needed, but watching for overprescribing and watching for red flags for substance use or substance abuse disorder.
That is all the time that we have for questions. Thank you all so much. I did see a lot of patterns about Medicaid and Medicare coverage, so I think that's something we could work on the Max Technical Assistance side to provide you with more information. So look out for that. Definitely look out for our emails and everything. But please join me in thanking Dr. Merritt for her time this afternoon. Our pain management talks are always great. We always get such great discussions. So thank you all for being online, and thank you, Dr. Merritt. I'm just going to save the chat, end the recording, and then everyone can feel free to log off.
All right. Thanks, Bridget. Thanks, everybody. Appreciate y'all's interest.